Hi, good evening. This is another series on our YouTube on experiences in medicine. And in this case, we're going to talk about current COVID treatment. And this is because we have added, um, I've been invited for several as panelists, listen to podcasts, listen to Zoom on COVID treatment, and there's a big gigantic debate over things that are being treated. And even for where I practice, there's lots of debate in which the control of treatment uh, are being, how do I say it, being handed down to doctors, and the autonomous practice of medicine has been removed in many of these institutions, and therefore you hear about a big organization which they call themselves something plus. I can't remember, Maths Plus, where they have methylprednisolone and so on and so forth. And there are all sorts of movements in hospitals where there's a brain trust, and the brain trust tells everybody this is how to have the treatment, and and organizations like this. And it's one of the sad parts that has affected hospital medicine in the United States, therefore leading to less trust in the system and less trust in what patients are receiving from physicians. And unfortunately, this is not how medicine should be practiced. However, since we are solutions rather than cogwheels, I'm going to talk in this small video about what are the current treatments we normally give to patients COVID, because I get calls from different parts of the world say, oh, how do you guys treat COVID in New York, because you guys have a lot of cases and so on and so forth. And I will talk about them and mention very briefly about why some of the treatments are being given. One of the things which I'll first of all quote is that there was a man who was in Hollywood. His name was Jack Valenti. And Jack Valenti said, it is better to know it and not need it. And that to need it and not know it becomes a problem. So he says it is better to know it and not need it than to need it and not know it. So essentially, this is what this YouTube recording is about. Mandela also said that a brave man is not he who does not feel afraid, but is he who conquers that fear. So because of that, that is why we are talking about these treatments. So what are the COVID treatments that we know about, and what do we do when a patient comes in? And how do we determine that somebody doesn't need treatment or not? Often enough, the patient is completely asymptomatic and is seeing a physician, then the patient may not need any treatment at all. And this we see often in young people, really. Some of it is embryological. I think the lung develops from when we're kids up until the age of 25. Between the age of 25 and 35, it stays about stable. And after the age of 35, we start to lose FEV1 every year until we die. So generally, people less than 35 generally are not developing COVID pneumonia that kills them, because COVID generally kills because of the pneumonia, even though you could have COVID that affects the kidneys, excluding the lungs, and so on and so forth. However, what do we do? Because this is the major area that COVID affects and why people die. So, many people are symptomatic, even when people say they are not symptomatic. And therefore, one of the biggest reasons why people are dying is because the assessment of the patient has become a little bit less than adequate. Despite the fact that COVID has one of the most loud and florid signs, often enough because in the Western world, especially the United States, our ability to listen to patients have actually gone down over time. And therefore, people's ability to be able to hear rills, crackles, which are abnormal lung sounds in a patient's lung, is actually very low. And the average patient, when the average doctor, I ask them, or as a resident, to listen, they tell me the patient's lung is clear. Doesn't matter whether it's a doctor, a nurse, everything is clear. But in reality, it is not. The patient has florid pneumonia. So the first thing is, one, the person has to be listened to by someone who actually knows how to listen. However, let's assume the person doesn't know how to listen. What are the simple ways? Checking to see if they are tachypneic, whether they are breathing faster than usual. Secondly, doing a simple 6-minute walk, meaning that you walk them, and if they drop using a pulse oximeter of at least 4%, it means that they are symptomatic. If they appear tired and exhausted, they are tachycardic, that means their heart rate is above 100, then it means that they are actually symptomatic. However, if they are seen in the office, a simple tool which should be available to every primary physician is a spirometry that should show a decrease in FEV1. This patient means that they are symptomatic and they need treatment. If the patient passes all these areas, it means that patient is not symptomatic and may not need treatment at all. So on an outpatient basis, what do? The most effective treatment is one, the monoclonal antibody treatment. And this monoclonal antibody treatment is underutilized. And for us in our office, if the patient is COVID positive, has signs that they're symptomatic to some extent, then we refer them to have a monoclonal antibody treatment. The most common ones we have, I think the first one I think was recognized was banilucumab, which is what we recommend, and there are now additional ones that have been approved, and this is what we will recommend in our office first. However, what are the other things we can do? We can actually treat them with oral steroids. At the beginning of the COVID, people claimed steroids made people worse, it spread the virus and so on, but now we know better. And how do we know better? We know better because of the study that came out from England. And that study from England showed that dexamethasone was useful and helped to reduce mortality in patients with COVID pneumonia. And therefore, this studies use 6 milligrams of dexamethasone. However, converting it orally is about 40 milligrams of prednisone, which is something which we are familiar with for many of us who are pulmonologists. And then often enough, we give it in a tapering dose on an outpatient basis, and that will help any primary care physicians who doesn't know what to do and to treat the patient on an outpatient basis. However, are there other treatments that are not fully recognized but may be of useful? Yes, it's a medication called Luvox, levofloxacin. There are studies that show that if you give it at about 50 milligrams twice a day or 50 milligrams 3 times a day over a 14-day period, it will reduce that person's development of florid COVID pneumonia. Now, let's assume that you have failed. You have used the 3 things, or they didn't have the opportunity to get a monoclonal antibody. They didn't have a opportunity for a doctor to actually see them. They just went on urgent care. The urgent care just told them you have COVID and just sends them home, which is one of the fallacies of our system. Our system will work better if patients are seen by primary physicians who actually will follow people longitudinally. The rise of urgent care centers and emergency room as a place for care has actually led to the increase in the amount of deaths that have occurred from COVID. However, in a person who's able to see them longitudinally, in this case, they actually will have a better outcome. Now they get hospitalized, what happens? So for most hospitals, we give them dexamethasone based on the study from England. However, we can, depending on how severe, they may need more steroids than that amount, because often enough, especially in the Western world, there are additional underlying steroid responsive illness that are occurring, asthma, COPD, and these things will require an increase in the amount of steroids that you normally have given just for treating COVID in itself, and therefore giving them a higher dose of steroids than what was present in the study usually make the person better, and the cost is inexpensive. Now, what else do we give? We give remdesivir. You may see from my head shaking that, yes, it's FDA approved, but has it actually done any dramatic difference? Probably not as much, but we don't have that many things that we use. Now, people ask me, what is remdesivir? Remdesivir is just an antiviral, and in reality, it was first of all developed for use in hepatitis C, and then subsequently it It was developed for use in people with respiratory syncytial virus, and then later on was thought to be useful in patients with Ebola and also in the Middle Eastern virus, and then later on in the initial SARS virus. And then when SARS-2 came about, this remdesivir was now used. The major reason is because it's relatively safe and compared to many other enteroretrovirals. And this is why, even though it doesn't really do any dramatic change in people, it sufficiently improves the people who probably have moderate COVID and actually makes them better. It may not change mortality in a mad way, and that's why WHO has rejected it. But the trials for this came from what we call the adaptive COVID-19 trial, which was published in the New England Journal of Medicine, and that is based on that. That's why we use it in the United States. There's another medication which we use, tocilizumab, which is also used in Nigeria, just like here. That also has been a major source of argument back and forth. However, I will mention that the recovery trial done in the United Kingdom had over 4,000 severely ill patients and has actually shown that it does make a change, especially when it's used in combination with dexamethasone. However, what's the difference? The difference is price, and price is always driven things. Tocilizumab was originally developed for moderate and severe rheumatoid arthritis, and then subsequently it was now adapted for treatment in patients with COVID. And in reality, it costs about 100 times more than a real simple steroid like prednisone or dexamethasone. And this is why hospitals are reluctant to use it. However, enough data is there despite the mixed results that are in the United States. The last result, especially, is a study called the Empata study, which is evaluating minority patients with Actemra, which was done in Mexico, Kenya, Peru, Brazil, the United States, as well as South Africa, showed clearly that tocilizumab does have an advantage in treatment. So despite what your hospital may say, and my hospital does, tocilizumab is part of the armamentarium that I use. Now, convalescent plasma. What is convalescent plasma? People who've had COVID before, in their plasma they have antibodies. Many people say, oh, it's just a useless thing, and the FDA now has up and down that, maybe we shouldn't have approved it or not. However, enough data lets us to know that if a convalescent plasma is rich in antibodies and high titer antibodies, they are more likely to do well. Fortunately, people who are donating this plasma do not know whether the antibody level is rich or not rich, and often enough when it's been transfused, nobody knows for sure what you are getting. However, in a few people who get a high antibody titer convalescent plasma, they seem to do well. But since it's a twist of the coin, then you do not know exactly what you get. So the best thing is to treat people early. As I've said, monoclonal antibodies are number one. However, outside the United States, most people are not going to have access to this medicine. So therefore, what is an easier alternative? There are two medications that are cheap, they're already on the market. Prednisone, methylprednisone is already on the market, doesn't cost them that much. And you can give a 12 to 14 day course, either using a prednisone 40 milligrams for 3 days, 30 milligrams for 3 days, 20 milligrams for 3 days, and 10 milligrams for 3 days, or just using a plain 40 milligram dose in patients who don't have diabetes and you're not worried about their sugars going crazy, and therefore treating them over that time period for 10 days. And levofloxacin, we've mentioned, also has been around. There's no extra cost, and outside the United States is something to do. There's something people talk about ivermectin based on some studies in Nigeria. I do not recommend ivermectin. Too little people have studied it, and therefore, even though people argue that it's a Western world against Far East, there are just not enough of the type of patients who have been used on. So tocilizumab had like 4,000, remdesivir had about 1,000 randomized control. So they're a bit larger, and therefore the recommendations are a little bit better. And that is why I do not mention it. Now, there are the guys who are the methylprednisone who says we should give high dose and so on. Yeah, they all fall in the dexamethasone prednisone range, and therefore giving those ones are probably reasonable. The people ask me about vitamin C, zinc. I don't think it makes a difference, and at least we know definitely it doesn't really change anything, and therefore giving it probably doesn't make any difference. Makes the patient better overall, but doesn't make any difference in COVID. Now, the last thing which I'll talk about, which does matter but doesn't matter once the patient is sick, is whether the patient had a normal vitamin D level before they came in, and then it turns out a low vitamin D level. Will you now give them vitamin D at that time? Will it make a difference? It doesn't make a difference. So it only makes a difference before they get sick, and therefore maybe a good recommendation now is that as part of our annual physical examination, making sure people's vitamin D levels are good will make a difference. So I've summarized what is it that will make people better, what is the current treatment in COVID pneumonia that we know based on data, this is what it is. And therefore, once you are faced with a patient, these are the decisions you have to make. Are they symptomatic? If they're not very completely asymptomatic, they are young, I've explained to you they are less than 35, there's no reason you may not need to treat. Or if they are symptomatic, you want to treat, and you want to treat effectively before they become sick. So lots of people are dying because of this judgment that is not being made on when to treat them and to treat them early. And once you don't treat them early and they become very sick, it doesn't matter what we give them, whether we give them remdesivir, whether we give them tocilizumab, whether we give them convalescent plasma, these patients invariably die. Doesn't matter whether we put them on a ventilator, we put them on non-invasive ventilator, doesn't matter whether we do prone monitoring or we don't do prone monitoring, they invariably, most of them will die because the time to treat them was early, and therefore lots of windows of opportunity are lost, and that is why we're having this. So what is the solution? The solution is massive vaccination. A massive vaccination will change the course of the disease. And how should the massive vaccination become to concluded? Not just to buy the vaccines, through primary care physicians, which has always been the solution to healthcare in the United States at the primary care level. Funding local practices, making it available to them, allowing them to be able to buy the storage, allowing them to have access, and this will make a difference both in the treatment of COVID as well as in the prevention of COVID. This is our recommendation on this video. Thank you.